Hello everyone, my name is Stephane Ganhym. I am a Doctor of Nursing Practice student at Melbourne University, and this is my DNP project presentation entitled Implementation of Routine Anxiety Disorder for Early Detection, Equality Improvements in. I would like to start by thanking my committee, which includes my chair, Dr. Teresa Galakatos, who has been an exceptional guide and resource since we started working together. I also want to thank Emmanuel Sango, my person, who gave me tremendous support and encouraged me when times were hard. I also want to thank my second reader, Dr. Snell, for her unquestionable leadership and her ability to keep the program a success. I would like to tell you a little bit about myself. I obtained my Bachelor of Science in Nursing at Bowie State University and decided to return to school to complete my Master's of Science in Nursing at Maryland University so that I could have an even greater impact on others. Finally, my passion for nursing research and my desire to continue providing the highest level of competent nursing care led me to start my Doctor of Nursing Practice program at Melville University. I currently work as a psychiatric mental health nurse practitioner at an outpatient clinic in Washington, D.C. There were no financial disclosure for this. Now, I would like to talk about generalized anxiety disorder, which is the most common anxiety disorder and affects a large portion of the population in the US and around the world. It is estimated that approximately 39 million adults in the US are diagnosed with GAD. It is also estimated that 12% of the population at some point in their life had the characteristics of GAD, with women two times more likely to experience GAD than men. According to multiple research studies, the elderly population is most commonly diagnosed with GAD due to their vulnerability and complications from other health issues. Given the current statistics about GAD, it is important to look at its burdens in different areas of life. Indirect burdens of GAD include impaired social functioning, poor education outcomes, declining job performance and productivity, and unstable personal relationships. GAD places a strain on healthcare as a whole, resulting in direct burdens such as increased costs. The lack of treatment and non-adherence to treatment cause worsening medical conditions, substance abuse, and undiagnosed GAD. Knowing the prevalence of GAD and its burden, it is alarming that only 37% of the population seeks and receives treatment despite the availability of tools to screen for GAD and various treatment options. Now I want to discuss pharmacologic and non-pharmacological treatment. When screening and detected early, GAD prognosis and treatment outcomes are excellent. Various treatment options are now available to manage conditions like GAD. Antidepressants and anxiolytic drugs are some of the first line treatments for patients diagnosed with GAD. Serotonin selective reuptake inhibitors, also known as SSRIs, and benzodiazepines are the most commonly used classes of drugs. Non-pharmacological treatments such as yoga, meditation, guided imagery, deep breathing, stress management, psychotherapy, support groups, and cognitive behavioral therapy are also commonly used. Both pharmacologic and non-pharmacological treatment can be used as monotherapy, but research studies have demonstrated that combination therapy provides better health outcomes. Now, I want to discuss the purpose and aims of this project. The combination of my personal experiences of seeing firsthand the devastating effect of GAD on a family member and the negative effect on my patients in practice sparked my interest and motivated me to seek solutions by implementing this project. The purpose was to implement a routine GAD screening on patients seen at the clinic to detect GAD early and initiate referrals and treatment. Prior to the project being implemented, patients were only screened when they self-reported symptoms of anxiety, including increased substance abuse or after ED visits for anxiety complication and when occurring at the clinic more frequently. There were many cases of patients being treated in the emergency room or hospitalized for anxiety attacks. Ultimately, the aim was to provide immediate resources to patients diagnosed with GAD. The big question for this project was in adult patient and one outpatient clinic. How does the implementation of a routine GAD7 screening compare to just-in-time screening impact outcomes overall? Now, I would like to talk about the theoretical framework. The theoretical framework used for this DNP project was the Plan, Do, Study, Act, also known as the PTSA model, which is also known as the Rapid Cycle Improvement Model. This model is applicable in various organizations and industries. For this project, the plan phase defined the objectives of the screening and staff education. The do phase evaluate the patient diagnosed with GAD, obtained reviews the medical chart. The study phase compare findings with expected results, then summarizes outcome. The act phase evaluate whether this practice change should be adopted, or abandoned. Now let's look at the review of literature. Implementing a routine screening may lead to early detection and treatment and increased diagnosis. The review of the literature supported that GAD screening is currently underused in the primary care setting despite the availability of a reliable and valid tool like the GAD7 screening tool. The primary care office is the ideal setting to capture and establish a diagnosis of GAD because most patients are initially seen by their primary care provider, who generally have a good relationship with their patients. However, some barriers exist and have made the implementation of this practice by primary care providers difficult. Some of the barriers include time constraint, physician lack of knowledge, insurance regulation issues, the presence of multiple medical demands, and symptom attribution. Just like we discussed the importance of routine screening, the consequences of lack of screening and treatment of GAD are worth considering. They can place patients at risk of severe and life-threatening conditions and risk of developing physical illnesses. Now let's look at the methodology used in this project. The quality improvement project took place at an outpatient clinic in the Northeast region of the US. A quantitative, explorative, retrospective chart review of patients seen at the clinic during the 30 days of the pre-implementation period and the 30 days of the post-implementation period was used. Staff at the clinic received training and education on GAD, its negative impact, the importance of screening routinely, and the proper administration of the GAD7 questionnaires and the interpretation of scores. IRB approval for the project was obtained from Maryville University. Now let's look at the data collection. Before collecting the data, it was important to ensure that the inclusion and exclusion criteria were met according to the IRB. For this project, patients had to be between 18 years and 89 years old, with no prior or current history of GAD diagnosis to be included. Patients younger than 18 years of age and patients older than 89 years, and those with current or history of GAD diagnosis were excluded. There was strong evidence in the literature supporting the reliability and validity of the GAD7 screening tool for the diagnosis of GAD. This tool consisted of 7 questionnaires about patient symptoms. The scoring cutoff point range from minimal, mild, moderate to severe, and patients who had a score equal to or greater than 8 received a diagnosis of GAD. Now let's look at the data analysis. The data analysis part of the project is important because it provides an overview of the descriptive statistics, quantitative methods, and variability that are essential for the project's result. Descriptive statistics describe data and synthesize the finding. A z-test for the difference of two proportions was used to analyze and compare the number of GAD diagnoses pre and post implementation of the GAD screening. The z-test was used to determine if there was significant difference between the sample and the population mean. The standard deviation, data disbursement, homogeneous and heterogeneous constituted the variability of the data and helped to determine the difference between the highest number and the lowest number in the data set. Now let's look at the demographic of this project. During this project, descriptive statistics provided an analysis of the demographic data and the patient age range during the pre and post implementation. 61.3% of the patients seen at the clinic during that time were female compared to 38.7%, which were male. Black African American represented the largest ethnic group at 59%. That was followed by Caucasian, Hispanic, and Asians at 19%, 14%, and 8%, respectively. Patients in the age range of 60 to 69 represented 30.3% of the patients seen at the clinic during that period. As you can see, the patients in the age range of 60 to 79 were the largest number of patients screened. Now let's discuss the result. The results section of the project is the most important part of the project because it summarizes and presents the findings of the studies and answers the initial pick of the question. The p-value less than 0.001 was less than the significance level of 0.05 and the null hypothesis was rejected. There was sufficient information to suggest an increase in the ratio from pre to post intervention. The confidence interval suggested the true change in ratio from pre to post intervention. Since 0 was not included in the interval, there was significant evidence to show a change in one direction. The achieved power of the study was 1, which was considered high in strength. The pre and post group comparison showed statistical significance with z equal to -1.9600 and p equal to 0. The post group of routinely screened patients was statistically higher than the pre-group of patients not routinely screened, which indicated that the increase in screening resulted in an increased number of diagnoses of GAD. This part of the results section analyzed the total number of patients seen compared to patients diagnosed after the screening. A total of 185 patients were seen at the clinic during the 30 days of the data collection before the project was implemented. Of those 185 patients, only 28 patients, which represent 15.14%, were screened for GAD and 22 patients met the criteria for GAD, representing 12%. A total of 252 patients were seen at the clinic during the 30 days of the data collection after the project was implemented. All 252 patients, which represent 100%, were screened for GAD, and 190 patients met the criteria for GAD, representing 75.4%. This part of the results section analyzed the number of patients seen compared to patients screened. It showed that 22 out of 28 patients screened were diagnosed with GAD during the pre-implementation period, which represented 79%, meaning that if more patients were screened, more GAD diagnoses could have been made. This was a compelling finding because it clearly showed that the lack of routine screening may have resulted in misdiagnosis and untreated cases of GAD. Because patients received a GAD diagnosis with their scores when their scores were equal to or greater than 8, this part of the results section analyzed the total number of patients who had a score of 8 or greater. Of the 252 patients screened, 62 had a score of 8, which was the highest among all scores, and 190 patients scored 8 and above. None of the patients had a score of 1, 2, 13, 14, or 15. This part of the results section analyzed the symptom that was most reported by the patient from the 7 questionnaires. The question related to not being able to stop worrying or control worrying had the highest score. The question related to worrying too much about different things and the question related to feeling nervous, anxious, or on edge were second and third respectively. This part of the results section analyzes the severity of patient symptoms based on their score. Of the 252 patients screened, 183 patients met the criteria for none to mild, 69 patients met the criteria for moderate, and no patient met the criteria for severe. Interpretation of results. The result of this quality improvement project aligned with previous research studies that supported the advantages of routine GAD screening in a primary care setting to detect cases of GAD diagnosis that would have likely gone undetected and undiagnosed. The result also showed that routine screening for GAD promoted early detection, timely treatment, and improved outcomes. Discussion of limitation. This section examined whether the findings of the project were generalizable and sustainable. The author determined that the findings were reliable and generalizable because they could be broadly applied to different primary care settings. The project used a large and diverse sample size of patients from different age groups, gender, race, and ethnicity, making it a good representation of the overall population. The significance of this project made it sustainable. The fact that the GAD, the GAD7 tool was already embedded in the clinic EMR made the screening process easier and sustainable. Now let's discuss post-implementation insights. This section examined the barriers and facilitators encountered. The only barrier encountered during the project was the registered nurses and medical assistant reluctance to embrace the change in the beginning. They initially perceived the implementation of the routine screening as additional work for them. However, when the author explained the importance of early detection of GAD to improve the patient overall health and negative effect of that on the patient, they were happy to do what was necessary to help their patient. The main facilitator was the fact that the PI and staff at the clinic were easily accessible and provided the researcher with all the information and resources needed to complete the project. Another facilitator was the accommodation and flexibility that the author received from the clinic to schedule meetings with the staff as often as possible. Having the GAD7 screening tool already embedded in the clinic system was convenient and conducive. Now let's look at implications. It is important to assess the implication of the project in practice and future research, in healthcare policy, and in quality and safety. Screening patients routinely is one of the best approaches to not only identify GAD early, but also mitigating its effect on people's lives. In practice, routinely screening patients for GAD not only promotes an early diagnosis, but also improves the patient overall quality of life by preventing suffering associated with anxiety symptoms. This quality improvement project is consistent with other studies and can serve as a reference for future research on the subject of GAD screening in the primary care setting. The need for a push for legislation that encourages funding, effort, and promotes screening and access to mental health services and GAD screening in particular is critical. Increasing public awareness through community outreach program and sensibilization is a key component to the recognition and prevention of GAD. Policy changes should aim at empowering healthcare professionals with the tools and resources to advocate for their patients and positively impact their health by screening for GAD routinely. Recognizing and eliminating barriers to screening and treatment of GAD in the primary care setting was essential for the maintenance of quality and safety. Screening and treating patients for GAD can prevent suicide and prevent complications from medical conditions and alleviate safety concerns. Now let's talk about the benefit. The benefit of this project to the clinic were considerable. Patients at this outpatient clinic benefited from routine screening and follow-up protocols that identified and expedited timely referral and treatment. The staff benefited from the education and training on the use of the GAD7 and how treatment can positively impact the patient's outcome. This outpatient clinic serves vulnerable populations who experience health disparities and are impacted by social determinants of health. In conclusion, GAD is a serious health issue. Primary care providers can diagnose and refer patients diagnosed with GAD to a mental health provider for ongoing treatment and care. Findings from this quality improvement project supported the use of routine screening. Early detection and treatment lead to improved health outcome. Opportunity was identified at this outpatient clinic. Other clinics and healthcare settings could benefit from routine screening. Here are my references. I want to thank you for listening. I am happy to take your questions. Feel free to post your questions here in YouTube or email me your questions at stage1@live.maryland.edu. That's my email. And have a great day, everyone.